I can see that we have my colleague Tony Pansell connected. How are you, Tony?
I'm fine, thank you, Jörgen.
Yeah, nice to see you again.
Yes.
Tony is an optometrist. He works at Karolinska Institute, and he has a PhD, and I've known him for many years. I don't know when we met first time, but it's quite some years now. Yes,
Yeah.
he works with an area that I don't have any experience on, and it will be interesting, I think, to listen to you, and then we will discuss afterwards about filters. Perhaps you want to present yourself a little more, Tony, or say what's your specialty and so on. So please, Tony, the floor is yours.
Thank you, Jörgen. And thank you, Mats and Frida, and the team at Multilens for this invitation to this ML meeting event. Always nice to be working with you. And as you might see, I'm sitting at home, so I'm not in my work office, so I excuse the background. But on this little talk, I will describe the day I'm working in. I mean, the typical patients I meet in my work, and the benefits of using colored filters in this patient group. But let's just start with the background. So I'm an associate professor at the Karolinska Institute. I'm a research group leader, and we have quite a large group. We are close to 20 persons in the group, and we have a big interest in visual function. So I have pediatric ophthalmologists, we have optometrists, orthoptists, eye nurses, speech therapists, and computer linguists, all focusing on vision function. And in this work, I've been in contact with patients with traumatic brain injuries. So both clinically, I work with patients with the brain traumas, and I also have a big interest in the research to better understand what a brain trauma actually how that will affect visual function, and maybe more interestingly, what can we do to help our patients. So that's a short description of me, and I will present today's talk, which we name as Clinical Procedures and Scientific Evidence of Using Colored Filters. So I will both talk about how I proceed in working with filters, when do I test filters, and how do I pick the correct filters for each patient. And this is really based on my experience from working clinically. So I heard that you had a great talk yesterday from Lene, and she is also working with brain trauma patients like stroke or brain trauma, acquired brain injuries. And so I hope that I can complement her talk with some aspects. And then in the last part, we will actually go through the scientific evidence of using colored filters. And that is a work that I've done for Multilens now during this spring. And I will tell you more about what does science tell about using colored filters. Is it only psychology, or is there really some mechanism that it changes in the vision function? Since I'm working in a neuro-ophthalmology department, I meet a lot of patients with stroke, brain tumors, they have brain infections, etc. And my research is maybe most on MTBI patients, concussion patients, what we call the post-commotio syndrome. Those patients that suffer from a concussion and that does not return to normal function within a couple of weeks. We usually put the diagnosis post-commotio syndrome after approximately 3 months if you still perceive a lot of symptoms, MTBI symptoms, then you will have this diagnosis. And we also meet patients with PTSD and now also the chronic COVID symptoms we see. And they behave just like our brain infection patients. They are very equal. When you meet them, they almost appear like they have the same brain damage mechanism. So when I meet patients, and I usually have a quite open question about how is your vision? Can you see? Most patients say that, no, I have no problems with my vision. It's all the other stuff, like I'm tired and I have brain fatigue, etc. But when you go into the anamnesis, the history, and when we really start digging into the problems, almost everyone tells that, well, I have no problems with my vision, but I can't read for any longer period. That means I can read maybe for 5-10 minutes, and then it becomes impossible, because then you have all the symptoms coming. I can't go to the supermarket any longer. I can't go to any place where there is a lot of crowd of people, because when I enter this room, all the symptoms is coming back to me. I often bump into things. They feel clumsy. They walk into chairs. They bump into stuff when they walk at home. When they are sitting in the car, they have to look down on their feet because they can't look out in the windows, because they will have dizziness, vertigo symptoms, which also will increase all the symptoms they had from maybe from the concussion or the brain trauma. They usually tell about getting sick when they travel. And they feel, many patients explain it like they feel they are out of phase with the world. They can perceive the world, they can perceive everything around, but they don't have the energy really to take everything in. And it feels like standing outside watching a movie. The reason for, as we say, I mean, there is no brain trauma, there is no brain disease, there is no brain disorder that will not give any kind of vision symptom. The reason for this is, as you can see in this picture, I mean, the eye bulbs are in the frontal part of the brain, or the frontal part of the face, while the visual cortex is in the back part. So all the axons from the retina has to travel through the whole brain. And this is just the primary visual pathways. And then we also know that after entering the posterior part of the brain, the analysis of the image, the perception of what we see continues in what we call in the dorsal and the ventral stream. So a very big part of the brain volume are involved in vision. And of course, if the brain has a trauma or a disease, vision will be affected in some way. So our patients, they usually complain of photophobia, diplopia, blurry vision, eye strain that also increases when you start using your eyes, such as reading or looking out the window when you are traveling. They also have visual perceptual problems, and of course, if you have a damage to the brain, like a tumor or a stroke, you will also have visual field defects almost always. So it's very common. So this open question to our patients, do you have any problems with your vision? And usually when they start saying no, we know that they have not really been perceiving maybe all parts of vision function. So to really stay in the beginning and really asking our patients how is your vision function working when you are walking, when you are trying to read, when you're eating, when you're trying to recognize something, then you will have a better answer on that question, how is your vision affected? So I'm an optometrist, And my colleague and good friend, Kenki Freda in US, and his colleague Diane Ludlam, they came up with this conceptual model of optometric vision care. And this is for mild traumatic brain injuries, but I have experienced that this works very well in a neuro setting when I meet patients. So it does not have to be concussion. It can also be my brain infection patients or stroke patients. And this is a pyramid explaining where should we start? What is the basics of helping a patient from vision complaints or vision disorders after a brain disorder? So in the bottom, you find the basic vision examination. That means a normal, regular visual examination, finding hyperopia, myopia, astigmatism. And the idea is here to put on spectacles for distance and for near, and to allow a sharp image on the retina. Remember that most of the patients we are talking about now, as Jörgen said, have full visual acuity. They have no retinal diseases normally. Usually they have full, so-called full vision. They have 20/20 vision, and still, even if they can see very well on the test chart, they still have a lot of complaints. So this is not a matter of visual acuity problem, but the basic part of starting to treat the patient is to give them the correct spectacles for distance and near. When we come up to the second level, we go into the oculomotor problems. We know that to focus on near distance, it's not only optics, it's muscles. We have accommodation in the eye. We have convergence that allows the eyes to converge, to focus on near. And for, let's say, when we are reading, we need saccadic eye movements, moving the gaze over the text. So here is more of when we go into vision therapy, there is no spectacles that can really improve those functions. We can compensate with near addition, we can compensate with prisms for if you have a convergence insufficiency, for example. But to really improve the functions, we need to start exercising. And that is something that I do in many of my patients. On the third tier, we will find the non-oculomotor problem, which are very common. And here we come into the photophobia and to something that we call the visual vertigo. That is looking out the window when you're traveling and you feel dizzy, or you will be nauseous. And you have to close your eyes or look into your feet, or you can't scroll your mobile phone because you become dizzy. All those problems are well known, and we also have ways of treating this. This will not be the scope of this talk, but this is, I have 2 PhD students right now. We are working and digging into visual vertigo, the mechanisms, what it is, how can we treat it. And in the top tier, we have perceptual dysfunctions, depressions, anxiety, etc. So even if this says optometric vision care, the basis is optometry. The top tier, we need more, this is more of a co-work together with all the other specialities in medicine, like psychological help or neurological help, etc. So the principles for a vision treatment is 2 parts. We have the optical solutions, and we have number 2, rehabilitation. And in this part, I will not talk about this rehabilitation, but we are doing vision therapy because we want to improve accommodation. We want to improve convergence. We want to improve eye movement control. But now today we will talk about the optical solutions, and this is for correcting the refractive errors. We can compensate for some of the oculomotor problems. We can give filters for photosensitivity, etc. So the first part is really to relieve and reduce the discomfort, while the rehabilitation is to improve something that you have lost in your brain trauma. But we will continue with the first part, optical solutions. And there are two principles for optical treatments. The first part is corrective. That is typically what you get when you go to an optometrist asking, or an optician, and you will have a vision exam. You will find, you will have spectacles compensating for hyperopia, myopia, astigmatism. That's really the basis, and this is corrective treatment. When you put the spectacles on, you will have better visual acuity. If we put on prisms to eliminate diplopia, we will regain fusion, and hopefully we will have stereopsis. This is something that we can measure in the examination room, and we give this correction based on that visual acuity is increasing, or that the patient will regain fusion and stereopsis. The second part is not that well known, and this is really something that I try to tell my colleagues, and this is about relieving treatment. We know that patients with brain trauma, they have a lot of symptoms. They can see. They have no problems seeing, but they will become tired after 5, 10, 15 minutes after reading. So we have to find a solution how to relieve, to reduce the effort. So as I say, save energy. This is a weird way of explaining what we're doing, but when I'm talking to my patients, they realize immediately. So when I'm telling that I will give you those spectacles because in this way you can save your energy. Oh, wow, thank you. They immediately understand what we are aiming for. So it's not better visual acuity, it's really to relieve, to make it easier. This is usually with plus addition, +1, and some base in prisms. Even if you're 20, I mean, you're not a presbyope, you don't need progressive lenses. You don't need near addition to read. But in those patients, when I put up some text and they have their normal distance spectacles on, when I just put on +1 in front of them, the normal response is, wow, this feels so nice. Do you see clearer? But no, it becomes a little larger, but it feels very good. And when you remove the plus lenses, they say, oh, wow, they can really feel how the eyes start working. So that's a very good pedagogic way also to explain for the patient that now we will do everything we can to have your eyes relax. You told me that you can only read for 50 minutes. We will try to extend that with those spectacles. Maybe you can read for 20, 25, maybe 30 minutes. And when we are in this relieving treatment, it's really about the color filters and the comfort filters. And this is what we will talk about right now. But the last part, the relieving treatment, is not evaluated by higher visual acuity or better stereopsis. It's really about comfort. How does it feel? If the patients would wear their distance spectacles and they have this near or text reading, and when I put over the +1 and they react like, oh, that was not nice, I will definitely not give them +1 spectacles, because if it doesn't feel well, I will not prescribe near addition to them. Then I will go instead into vision therapy, start doing accommodative exercises. Okay, just some short words about filters. As Jörgen have told you, there's different kind of filters, and we differ between the gray, the edge, and the comfort filters, and they really behave differently from an optical perspective. Gray filters, or normal sunglasses, another way of calling them is neutral density filter, ND filters. And the reason for that they are called neutral, that means in the first graph, as you see up here, I hope you can see my cursor, but it says transmission OD in the top in top of the graph. You can see that we have the visible spectrum. This is wavelength. So we have the short blue wave and we have the red high frequent light up at 700. So in the visual spectrum, you can see that the curves are flat. That means that if we have a dark ND filter, that will really reduce transmission. So they will be perceived as very dark. And the lighter we go, so light gray and the lightest one, allow more light, of course, to be transmitted through the lens, refracted. The difference between an ND filter and the edge filters is that an ND filter will not abolish color vision in the same way. I mean, everything will become darker, but yellow will still be perceived as yellow and green will still be perceived as green when you're using a good ND filter. So that can be very good to think about, as Jörgen also told you about. When you're applying the edge filters, they will definitely change color vision. As you can see here down in the bottom graph, we have typical edge filters or cut out filters. And if we take the yellow 450 filters, as you can see here, that meaning that all the light below 450 is removed. So the transmission is a 0 from the bluish and the bluish light, only allowing light from 450 and above. And this is usually what we also call a high pass filter. So light with a higher frequency than 450 will be let into the lens, while all the lower light, the low pass, is filtered out, removed. This will influence on color vision, since color vision is based on 3 RGB, red, green, blue. And what the brain does is really to compare the channels. So to perceive green, we need a certain amount of stimulation of all channels. If we remove one channel, meaning that the brain will perceive that is one part of the spectrum is missing, and we of course will perceive another color. So edge filters, they are beautiful to increase contrast, but they will affect color vision. Then we go into today's topic, comfort filters. And as you can see down here in the bottom right corner, we have an ML filter compared to a grayish filter. This gray filter is really not that flat. I should say this is not an ND filter. This is a gray. It appears gray. But as you can see here, the blue ML filter allows quite a lot of 400, the bluish light, to enter, blocking out the green light and allowing the higher frequency again. So this is a typical comfort filter. So they really don't behave like the gray filters or the edge filters. You just let some specific parts of the spectrum letting in. So they really differs. So when we say edge filter or comfort filters, that's not just some marketing. It's really based on the physiology, or the physics, I should say, the physics of the filter. So my test procedure when I'm working with filters, I know that Lene has her favorite, and I can say that the XO2. I received the XO2 now during the spring. I've been working with the ML for many years, and the Sapphire and Emerald. But the typical way for me to fit filters is to start doing the history with the patients. I'm asking about how vision is working. I start doing the normal vision examination to see if they have hyperopia, myopia, astigmatism. So I start with that part. And then I prescribe near addition, base-in prisms, base-in prism if they require. And then in the end, I go into filters. And this is really to get the extra comfort, to see if we can help the patient even more than just giving a sharp image of the text read. So I usually start with the ML, the 41. and I always go for the dark ones. I'm not sure that Lena might go for the medium, but from my experience, I start with the dark ones because I know that those are usually the ones that are prescribed. In the end, I will always try to reduce, but I will come back to that. I start with the ML41. I put them over in biocovers, over the trial frame, and just ask the patient looking around, look at the visual acuity chart, looking around in the room, talking to me, and maybe looking at the smartphone on an iPad or something. Then we just change, and then I usually go for the blue. The pink and the blue, the typical response is that they take on the ML41, they sit with them for a while, then change to the blue. And the blue, normally they feel, but wow, ooh, this is really not comfortable. And then you can start talking about, can you experience that there is a difference? So colors is really doing something with you. Yeah, blue was really bad. I could really feel how my head was reacting. And then I go over for the Sapphire and Emerald, etc. And usually I have to tell them about, because when they start putting on the ML41, they say, no, there is no difference, because they are looking at the acuity chart. So I say, but this is not about acuity, it's more about comfort. How does it feel? So then they have the correct mental state, how to perceive the filters. So sometimes I start in the other end. Which one of the filters is the worst one? Which one triggers the most symptoms? And very often it's the blue filter. But I have a lot of patients wearing the blue as well. So you can't just, even if I have a group of MTBI patients and they feel very equal and common, they're the same age, they are, there is no really hint to know which filter to pick. We have to try it out. And most of my patients, they find the ML41 most comfortable. Most people find the bluish to be the worst one. So after they have put out the worst or the bad ones, we can really go to see, okay, so which one was the best? And if you find the ML41 as best, they can compare without and with, and I say, oh, it's much nicer with the filters. When we have found the correct filters, I always try to reduce, going to the medium with that filter and asking, can you still perceive the same comfort? Yes, this is also nice. So the idea is always to give the brightest version of the filter, always. But I should say most of my patients, they leave with the dark filters. But I agree with Lena that the idea is to reduce the filter tone after when we meet the patients again after half a year or after a year, really to try to get rid of this adaptation so they don't get used to wear filters, because if you have the photophobia problem, we know that we have to reduce successively to brighter and brighter version to get well. So there are 3 effects. You can see in the bottom, we have the wow effect, and this is really the jaw dropper. Patients feel, but wow, this is the best filter. It's selling itself. When we have this wow effect, we have found the filter. But we also have the filters that when the patient put them on, they look around and they feel, but when they take them off, but oh no, it was really nice, but they did not really, it was not really the wow, but after adapting to them for a while and they take them off, they realize that, oh no, but this was really nice. I can really feel that my eyes are relaxing, or something in the head, my headache is relieved or something. And it's really immediate, this response. My patients very often explain, when I put on the filters, I can really feel how my headache is just disappearing. We have no idea what's going on, to be honest. But we have seen this so many times right now. So there is something very exciting with the filters. And then, of course, we have the no effect. I should say at least 50% or maybe a little less 40-50% of my patients say, oh, it becomes very pink. The room is pink, or the room is blue or green. Okay, can you perceive anything else? But no. What am I supposed to tell you? I mean, they don't really understand the concept of filters. So then we know, okay, this is not the patient that should wear filters. I usually, and I always do this testing in the examination room. I never lend away filters actually to my patients because I don't have filters to leave to the patients. That would be the best way to do it, but I just do this test in the end of my test session. I should also say that I always book my patient for 60 minutes, so I have some time to do this. Okay, so the last part, the scientific evidence of treatment effects from using colored filters. And this was really when I was in contact with the multi-lens, and I realized that this was a big problem. There is a what is the evidence of saying that the comfort filter is a medical device? So since I'm a researcher, I'm quite used to do reviews, making research, the scientific, to analyze the scientific background or hypothesis to realize what's the strength, how many studies are there supporting this idea. So we did, and I decided to make this work when I started to do a search on the PubMed. PubMed is the NIH, the big database for scientific articles in the medical field. So this is a huge library, and I've done, many millions of articles. So as you can see up here in the search field, it says optical and filter and green or blue or pink. So this is a typically search string which we add to pick out articles that has those search strings or search terms in the articles. So we're searching for something about optical and filter, and it should have something to do with comfort and something with filters. This is just examples of search terms, and I did many. So we have only included original articles, meaning no reviews or case reports. We have only included study designs with a control group, so-called case control designs. And the reason for excluding case reports is that you can't really conclude anything by just putting on a filter on a patient saying, oh, this is really nice. We have to take a person without, let's say, AMD. We need a group of AMD, age-related macular degeneration, and to put on filters. And we also need a control group with persons with the same age, the same sex. But the only difference between the two parts is that the control group, they don't have AMD. So we need a group to compare with. And they should be compared in the same ways. They should also be prescribed filters. And then after a while, you can measure or ask them, or in some kind of extra data telling what the filters are doing. So we have only included study designs with the control group. We have included all filter types, and we have both included objective and subjective data. I will tell you about that soon. So I found 637 articles, and I read all the titles and abstracts of those. 46 of those were downloaded, meaning they were really interesting because they were really picking in this topic of filters and comfort. I have excluded many filters about, let's say, intraocular lens, and to put on a yellow filter to protect the eye from macular degeneration. I have excluded the articles about improving color vision. It's not really the topic here. It's not about color vision. So that meaning, I had 637 articles from beginning. 46 of those were downloaded to EndNote, as you can see in this screen dump, which is a program where you really can add up all the information. We can make notes. And based on this review of 46 articles, 34 of them fulfilled all the requirements, and those were read in detail. So typical symptoms in those papers are photophobia, headache, migraine, eye strain, perceptual visual stress or pattern glare, blurry vision during reading, and difficult reading. And the most typical etiologies, I mean, the reasons for the symptoms, was the Mire-Island syndrome, the macular degeneration, blepharospasm, traumatic brain injury, and migraine. So let's go to the results immediately. So I have divided this in objective improvement. And in the next slide, you will see the subjective improvement. When we say objective, that means that we are measuring an objective data. We have been using a machine. We are using, let's say, an eye tracker. We are measuring near point of convergence, something that we can measure with a high data quality. That's what we consider as objective data. And objective data has a higher power. I mean, it's more reliable, so to say. From a research perspective, we love objective data. It's not questionable. I mean, if you make the measurements correct, the data has a very high quality, and we can rely on the results. Subjective, on the other end, is something, I mean, it's not bad data, really not. It's just that you can't measure subjective data with the machine. You cannot put up like an autorefractor and measure the refractive error. Subjective is someone asking you, typically it's a questionnaire asking you, how do you feel, or what do you believe about this, or how did you feel before treatment, and how do you feel now after treatment? Extremely important questions, but the answers are subjective, and they are not really repeatable. If we make the same measurements over and over again in the same individual, it will vary much more, because it's a lot of perception, memory, the mood I'm feeling, I have when I'm answering the questionnaire, etc. So now this first slide is objective improvement. That means we are really measuring vision function. So we have case control. We have studies with the case control, with the control group, and we have objective data. So let's go to the blepharospasm. Blepharospasm is the disorder where the eye closes without any voluntary control. This is a neurological disease, something that we usually treat with Botox injections in the orbicularis oculi to allow the eyes to relax and to see. So blepharospasm, here for to say, we had 2 articles that fulfilled the criteria of being case control and objective. The symptoms they also complain of, it's not only that they are closing their eyes, they have photophobia. So when I read those articles, I could really see that when they prescribed the ML41, a neutral density filter, the 480 and 590 filter, both articles, that meaning 100% of the articles included in the analysis, could show an improvement. And that means a significant improvement. So that's statistics. It's not like it's no subjective. It doesn't matter what the patient says. It's really about if you can measure improvement with the filters compared without filters. So in this blepharospasm, the effect of the filter was improved reading and less blinking. As you can see here, we have the Mire-Island syndrome, the AMD, the blepharospasm, the traumatic brain injury, migraine, deafness actually, and near work accommodation. This is not a neurological disease or disorder, it's more of a dysfunction, the accommodative disorders. In the end, we could actually find 12 articles. So 12 articles about objective improvement. 8 of those could show an improvement, a significant improvement in vision function. I of course, we can send out this later with the references and everything, but I will not go deep into all those. We don't have the time. So I will just give you a very brief overview of what filters can do. So let's go into this subjective improvement. And then this is really more related to comfort. So we still have Meier-Eiling syndrome. We have the AMD, blepharospasm, traumatic brain injury, and migraine. But in this case, we only have 9 articles that fulfill the criteria to being a case control and that has subjective data. The typical symptoms are visual stress, light sensitivity, and headache. 8 of 9 could show a significant improvement. And here you can see that it says, I mean, I said that we will include all kind of filters. So we have filters mounted in spectacles, like the biocovers, but we also have precision tint by this intuitive colorimeter, where you actually prescribe the absolute correct tint, and this is measured by this colorimeter. And you can put plastic overlays over the text, etc. So it's really about all filter types, I would say that. So the effect of filters was less headache, improved comfort, subjective better visual performance, etc. That's the kind of output of those articles. So in summary, according to well-designed studies with a control group, so we can have an objective effect. We have 8 out of 12 articles really showing a significant improvement. We have 8 out of 9 showing that we have a significant improvement, meaning that we have in total approximately 3 of 4 articles that are well designed, that really are controlling for all conditions, can show an improvement. And I think this is quite impressive, to be honest. Let's conclude this talk. There is very few articles with a good enough quality to be included in a review. Most of the studies on color filters do not qualify, and usually they don't include a control group. And if we have no control group, we have nothing to compare with. So if we would include all articles just without control group, then we will have a lot of articles. And there is many articles really describing good improvement in vision function. But from a scientific perspective, we have to compare. You have to really to control for if it's a placebo effect or not. There are several studies with a good design. Let's say, if we are testing the ML41 filter, there are a paper that has made a very, in appearance, it looks exactly like the ML41. It's exactly the same pinkish filters, and we have the active ML41 filter. So they look both the same. And so the treater and the patient, they really don't know which one of the filters that is active, which is not active. And these kind of designs is really lovely from a scientific point of view, because then we can blind the study. It's really a third person which is not involved in data collection or in the analysis, knowing which one of the filters is active. So they are double blind, and they can really reduce the effect of placebo effects and the investigator's impact on the result. So there are some really nice articles, and they show a clear benefit of using filters. In conclusion, we can say that filters have a very positive effect on both subjective and objective vision function. 3 or 4 articles can really show an improvement. So it's not everyone, but many patients really perceive a benefit. The effect we find is usually that they help or they don't help. And this is actually very important also to say that there is no report or anything that has shown that it's dangerous to fit filters. you can't really impair. I mean, if you have a macular degeneration, you will not have more macular degeneration by a wrong filter. When we fit filters, we always go for the comfort, and we are going for the filter where they perceive as most helpful. And all this will really improve or not improve at all. So it will never be harmful for eye condition or for vision. The objective and subjective change, I mean, the data, they are not dependent. So that means if we can't find an objective improvement, that does not mean that we can't find a subjective. They does not really relate to each other. So it's so objective finding, let's say visual acuity, contrast vision, stereo vision, that is one thing. But even if we can't find any objective improvement, we still can find subjective improvement. And this is really what we're aiming for in comfort filters. Very often the choice of filter is independent of medical condition. It's not like if you have MTBI, you should always go for the ML41 or always go for the Esmeralda. We really have to try them out on each patient. And some, as I said, some will pick the pink ones, and someone will go for the blue ones. Someone will go for the purple ones. We really have to try. The only exception we find is ML41, which is always the best option if you have the blepharospasm. And that was also the reason why they developed, or it was launched, this filter. It was for blepharospasm. The last slide for review. Even if I'm absolutely convinced that the filters is really doing something about vision, but the mechanism is really not elaborated. We don't know exactly what is happening in the brain or in the eye. We can just see that vision function is improved in many cases. There is a lack of papers about multi-lens filters. The first idea was, of course, just searching for all the ML filters, but they are absolutely too few. There are many articles, but they are too few. So we can't make an report just only ML filters. So this is that means it's filters from all from the market. Properly matched color filters have a clear link to increased comfort. 88% of all articles can really show an improvement, and I think that's impressive. So my personal reflections on offering comfort filters to my patients. As I said, at least 50% of my patients prefer comfort filters. Of course, then in combination with correct spectacles, maybe near addition on near. But as Jörgen also said, I also prescribe comfort filters for indoor use and for outdoor use, for distance vision and for near vision. Some persons say that I only want the filters when I'm sitting in front of my computer. Others say, no, I just want the biocovers to put over when I'm driving the car. For many patients, the filters has been a life changer. Patients with a lot of photophobia, eye pain, oculodynia, or headache, when they put on the filters, it's just like turning the ache off. I have at least 4 or 5 patients. And for them, I mean, it has been a life changer. I mean, it's like having their life back. Most persons are not concerned about the appearance of the colored lenses. That was my first idea. I mean, how should my young patients with brain trauma, why should they walk around with pink filters? But they really don't care. When they feel what the increased comfort, they love their filters. And when I ask them, I mean, is it okay for you to have this kind of filtering in your regular spectacles? But, oh yeah, I mean, this is so nice. I don't care if it's pink. I mean, now I can see. And also to explain to the patient, I have found out is very important, to explain how they would help to reduce the effort and to reduce the pain or to reduce the photophobia. That's it. I think I have 10 seconds to go and I'm done.
Yes, thank you, Tony. I listened to your presentation some weeks ago on the specialty optometry conference that Multilens had, and I was very happy to see that you have found also for AMD and for the selective filters articles that really we can trust and that we can have use of in this field, and that there is scientific evidence. We have different speciality. I have worked with the selective filters and reduced vision problems, and you work with another type of patients. But still, it's the same thing. Comfort is the most important.
Yes.
That's what you are asking for. And I forgot in my presentation before to show what I've used many years in my clinical practice, especially for this with retinal problems. I have a flip with neutral density filter 50% gray and a 511 filter. And both of them reduce the light with 50%. And it's reducing and it's filtering. And that's a very good starting point to see and the reaction of the patient. How comfort is this or this? If you get a negative appearance here, then I don't think filter will be so useful. But for most patients with retinal problems, I get the reaction, fantastic. This is so comfortable. And then you can go on and try the different other filters that's available. And I don't know, we haven't discussed this, but I think you do similar tests when you meet your type of patients.
Yes, of course I do. I work both with the biocovers and the flips, really to find this. I mean, this wow experience. Usually you have a quite fast response if they like it or not. I can like the idea of lending home equipment to the patients, but usually, I mean, at least in the patient group I'm working with, the response is actually very fast. They need we need 5, 6, 7 minutes to really find out if they have any good experience of filters. So, I mean, I had some patients asking for coming back to try one more time, just going into the boutique. And one of the personnel can actually help them just to test to prove maybe 2, 3 filters once more. Yeah. But usually we are quite sure about. And when I take them back on a control after 3 to 6 months, they are so happy about the filters. And it's usually, if we have a successful test in the first minutes, it will be successful also in the continuation.
Yeah, I think that's many times what we experience also with the reduced and low vision patients. Yeah. And I just want to take up another slide. Because I looked into some of the papers that Tony had in the review. So if you could put up my second presentation. I found some of these papers was really interesting, and this is perhaps the most important one for the AMD patients, where they tested filters that are not ML filters, but very similar. And you can see the graph on the yellow, orange, and red and gray filters that they were testing, and was really a good improvement. And I think you agree with this, Tony, that this is scientific proof. It's not ML filter, but it's filters that are very, very close to the normal edge filters that we are using.
Yes.
There is also another group that did for on reading tested filters, and they got a significant improvement. And they also did a study with overlayers instead of putting in glasses, and got similar improvement. And we also found, when we discussed that some couple of weeks ago now, Tony, after your last presentation, that there are more articles related to filters and AMD. And this is a Spanish group who used copies of ML filters and also conclude that the selective filters improve quality of life, because that's what they were testing. They had a questionnaire to investigate the quality of life, and especially they found in visual acuity under 0.25 that or more advanced AMDs, that selective filter is really a benefit.
Yeah.
There are some papers that we can refer to about filters today, so we have some scientific knowledge. Yeah. And you also have some of the ones for the comfort filters, especially ML41. There are some proofs today, isn't it, Tony?
Yes. I mean, the articles that were included in this analysis really includes very close, I mean, either really the ML filters themselves or copies of the ML filter, or filters with very nearby transmission profile. But the idea of this review was not really just to prove that ML filters are working. It's more a broader perspective to show what is colored filters doing really with vision. And I think, as I said, I mean, 3 of 4 papers, well-controlled studies, can really show improvement in both objective and subjective data. And I think that's the improvement we need. I think maybe for the future, I mean, right now we are using the filters that you in multilens will give to us that work clinically, but maybe in the future we have to be more, I mean, having a spectrum of filters, because my experience from working with the brain trauma patients is that while some love the blue ones, others will have the green, others will go for the yellow, others will don't have any filters at all. I mean, they will go for the gray filters. So to have the opportunity to show the spectrum of filters maybe will be the future. But from my point of view, and based on what we found, is that there is no doubt about that colored filters is very helpful in many conditions and for most patients.
Yes, I agree. And I think it was really good that you did this investigation and review of available literature. And I also hope, as you said, that we in the future will have some instrument that can measure exactly what we want, what this patient wants to have, would benefit most from the curve of the filter, and we can specially design that. That would be great. So I think we have some questions also.
Yes, we do. There's been a lot of questions in the chat right now, and I don't think we have time to answer them all, unfortunately, but we will answer them later. But I think we can start with this question, Tony. Is decision refusal a common symptom for these patients? My experience with post-commotion patients is that they often have trouble making decisions, which makes subjective examinations like choosing which filter they prefer more challenging. So what's your answer to that, Tony?
Okay, that's a good point. I mean, if if it were purely a subjective decision, a matter of mental processing, I'm sure that it would not be that reliable. But from my experience, this is more of a reflex. I mean, either you put the headache on or off. It's not a matter of choosing. It's just a matter of feeling if something is happening. I don't find that as a big problem. If they are not experienced, and if you will not have this jaw drop, wow, phenomena, and if you will perceive anything, even if you take the filters off, then you will actually end up in this no filter effect. And then of course, I have patients that want to feel an effect, but they really don't. But then I'm just backing off filter and say, but no, we are not going for filters right now. So they should not be in that situation that where they have to choose some filter if we don't have this good immediate effect.
Okay, thank you.
Yeah, thank
More
you.
questions?
Yes, we do. So the next question, how long should a patient use the filter to have an effect from the filters?
I should say that if we go for my patient group, they will have an immediate effect when they put the filters on. When they take them off, the symptoms usually appear again. Some patients explain that their vision function works quite well in the morning, and when they are going into the fatigue state, or if they are starting having more symptoms, then they put on the filters. My suggestion is to start. I think there can be a benefit of actually using the filters even when they don't have problems, because we want to extend the period instead. We extend the period when they have a normal function, when they feel well, when they can still work for a while. It's more of a prophylactic treatment rather than a treatment to the symptoms. So I try to prescribe the filter into the spectacles, and they should wear them from morning. But of course, this is individual.
Okay, thank you for that. Many of the other questions I think we have to wait and answer a little bit later. Some regarding that some people want this presentation recorded so they can translate it to their language and so on, but that's a question you have to take later. We also have another question. We talked yesterday about these packages we made for post-COVID cases. How is your view on how well these filters can help in these kind of cases?
So I'm working. I know that my colleague in my research group, Jan Johansson, he's one of my former PhD students. He is now working very intensely with the COVID, the post-COVID symptom patient group, and they are doing 2 studies right now where they investigate how does COVID influence on vision function. And that is together with Linköping Universitet and Danderyds Hospital in Stockholm. So they are measuring post-COVID patients. I think they are measuring at least 150 patients. And what I hear from my colleague is that they appear like the brain infection patients. And we know that many of the brain infection patients, they have a good benefit of using comfort filters and to have reading specs to relieve eye strain when they're trying to work for some minutes or for an hour or so. It's really too early to say about the COVID because we have not really analyzed the results, but our feeling is that they behave like the brain infection, and so they will benefit from using filters. And I think that was also Lena's presentation yesterday, where she can also conclude that in Denmark, they start treating or fitting comfort filters to those patients. The big problem in the post-COVID is fatigue. I mean, they are exhausted by just walking the stairs up to the second floor, or just go out with a dog, or trying to make a sandwich, and then they have to go to sleep for 1 hour. So it's really a matter of fatigue. And if we can do anything to help them, I mean, of course, I am sure that the comfort filter is one of the options we have to offer.
Okay, thank you very much, Tony. As I said, there's too many questions to continue, so we will answer these questions in a later stage. But for now, back to Jörgen.
Okay, thank you. And as we can see, it's a big interest in filter, and I'm very happy that you have found a new patient group, and that is very helpful with this comfort filter. I also think that comfort filters can be used in reduced vision and low vision rehabilitation. So I see this as an addition. The more tools we have, and we will find more people that can be helped.